Okay, let's dive into this. Welcome to today's Explainer, where we're going to unpack a truly fascinating medical mystery. We're actually pulling our source material today from one of the most famous clinical case analyses in television history, the pilot episode of House MD. But, we aren't just looking at this as pure entertainment. No, we are going to break down the actual real-world medical science and the clinical logic used to solve a seemingly impossible case. It's an absolutely perfect exercise in critical thinking, diagnostic strategy, and maybe most importantly, avoiding the traps in critical thinking, diagnostic strategy, and maybe most importantly, avoiding the traps our own minds set for us. So if you love puzzles, biology, and learning how experts really think under intense pressure, well, you're in the right place. Let's get started.
I want you to picture this scene. It's just a normal weekday. A kindergarten teacher is standing in front of her class, mid-sentence, doing exactly what she does every single day. But suddenly, something goes terribly wrong. She loses her words. She tries to speak, but she literally can't form the language. And then, terrifyingly, she collapses right to the floor. Now, what initially appears to be a frightening but isolated neurological event is actually the very first clue in a complex, rapidly evolving diagnostic mystery. We are dropping right into the high stakes of this case, where every single second counts, and the obvious answer? Well, it's dangerously wrong.
Section 1. The initial attack.
So, to figure out what happened to this teacher, we need to shift our mindset. We really have to step into the role of a medical detective examining a crime scene. And in medicine, the crime scene is the patient's initial clinical presentation. We've got 4 major clues here on our evidence board. First, sudden aphasia. That's the medical term for the sudden inability to comprehend or formulate language. Second, a generalized tonic-clonic seizure, which completely explains the collapse and the physical convulsions that followed. Third, progressive neurological deterioration, meaning she isn't just having an isolated episode and recovering. No, her brain function is actively getting worse. And finally, the smoking gun. A brain lesion is discovered on her imaging scans. When you put all of these clues together, they strongly point in one direction. They suggest a structural lesion of the central nervous system. There is quite literally something inside her brain that shouldn't be there. But knowing there's a lesion is only half the battle. The exact cause? That remains a total mystery.
Section 2. The suspect list.
You see, a good detective never ever jumps to conclusions based on just the first piece of evidence they find. You have to gather the usual suspects. The medical team here initially built a broad differential diagnosis of exactly 5 potential culprits to investigate. Now, a differential diagnosis is essentially a doctor's short list of possible diseases that could be causing a patient's symptoms. By keeping this list broad, in this case looking at exactly 5 distinct possibilities, doctors actively prevent themselves from locking onto one idea too early and totally missing the real threat.
Section 3. Eliminating false leads.
This is where the real detective work begins. We're going to methodically interrogate our suspects and rule them out, one by one. This process is absolutely vital because it shows exactly how cognitive bias can lead you astray if you aren't careful. Now, what's really interesting about this slide is how the evidence systematically dismantles the most obvious answers. Look at the first suspect, brain tumor. With aphasia, a seizure, and a visible brain lesion, a tumor seems like a slam dunk, right? It's the most intuitive guess. But when they looked closer, the patient's rapid clinical progression and the specific details of the imaging just weren't typical for a primary brain tumor. The tumor theory didn't explain all the symptoms, so it had to be crossed off. Next up was cerebral vasculitis, which is an inflammation of the blood vessels in the brain. It causes progressive neurological deficits, so a pretty good suspect. But the team found 0 laboratory or radiological evidence to support it. Ruled out. Well, what about infective endocarditis with septic emboli? That's basically an infection in the heart sending tiny infected clots up to the brain. This definitely causes multiple neurological issues. However, the patient had no fever, no cardiac murmur, her blood cultures were negative, and an echocardiogram was totally clear. Ruled out. Fourth suspect, autoimmune disease. Sometimes systemic autoimmune issues manifest neurologically. But all her autoimmune blood panels came back negative, and a rapid decline just didn't fit that clinical course. Ruled out. Finally, a brain abscess. This causes seizures, focal deficits, and a ring-enhancing brain lesion, which actually matched her scan. But again, there was absolutely no convincing evidence of a systemic infection in her body, and the radiological appearance wasn't a perfect match either. So, we've gone through all 5 suspects, and every single one has been entirely excluded.
Section 4. The diagnostic breakthrough.
So, the investigation has officially hit a dead end. All primary suspects are cleared, but the patient is still dying. To crack this case, the team needed a major paradigm shift in their clinical logic. They had to stop looking at the evidence the same way and ask a totally different question. What disease can mimic a brain tumor while causing seizures and focal neurological deficits? This right here is the pivotal breakthrough. The lead doctor realizes that every diagnosis they've considered so far only explains a fraction of the presentation. You see, they'd been operating under the assumption that the mass on the scan had to be a tumor. But by asking this specific question, the focus shifts entirely. They are no longer hunting for a tumor, they are hunting for an imposter. They're looking for an infectious parasitic disease that's clever enough to wear a tumor's disguise.
Section 5. The true culprit revealed.
That paradigm shift worked. It's time to unveil the actual disease responsible for this kindergarten teacher's terrifying symptoms. The true culprit? Neurocystic sarcosis. Let's break down exactly what that is, because the science here is just fascinating. Neurocystic sarcosis is an infection of the central nervous system. But it's not caused by a virus, and it's not a bacteria. It is caused by the larval stage of a parasite called Taenius solium, the pork tapeworm. When these larvae enter the body, they travel up to the brain and physically form cysts right within the brain tissue, or parenchyma. Now think back to our patient's symptoms. When these cysts form in the brain, they trigger a massive inflammatory response. This localized inflammation is exactly what produces those sudden new-onset seizures. And depending on exactly where the cyst sets up camp in the brain, it causes focal neurological deficits, just like our teacher's sudden aphasia. And when you put the patient in an MRI or CT scanner, that inflamed cyst appears as a ring-enhancing lesion. To the untrained or biased eye, a ring-enhancing lesion looks exactly like a rapidly growing brain tumor. The parasite perfectly accounted for every single clue on our evidence board.
Now, a really crucial point here is that while this might sound like a bizarre one-in-a-million television diagnosis, neurocysticercosis is actually one of the most common causes of acquired epilepsy worldwide. It's a major global health issue. So understanding how this parasite operates isn't just fun TV trivia, it is vital medical knowledge that doctors across the globe use to save lives every single day.
And this brilliantly illustrates the core conflict of the whole case. On the left side, you have the expected brain tumor. That was the assumed primary mass causing the focal deficits. It's what everyone expected to see based on a quick glance at the scan. But on the right side, you have the actual reality, a parasitic infection of Taenius solium larvae, causing ring-enhancing lesions and severe inflammation. The initial brain image was incredibly deceiving because it offered an easy, plausible answer that was entirely wrong.
Section 6. The clinical lesson.
This brings us to the ultimate takeaway from this explainer, because this isn't just a story about a tapeworm, it's a profound lesson in critical thinking and the dangers of mental shortcuts. We're talking about avoiding anchoring bias. Anchoring bias is a psychological trap where you rely way too heavily on the very first piece of information you receive, the anchor. So step 1 to avoiding this: never anchor on the first diagnosis. Just because a lesion looks like a tumor doesn't mean it is one. Step 2, build a broad differential diagnosis. As we saw, a patient presenting with new-onset seizures and a ring-enhancing brain lesion should always trigger a wide net of possibilities, not just tunnel vision on oncology. And step 3, consider epidemiological risk factors. A really good doctor looks at the whole patient, where they've traveled, what they do for a living, what they eat, before concluding that a spot on an image is a death sentence. This logical step-by-step process of casting a wide net and letting the evidence, not your assumptions, narrow it down is exactly how top-tier doctors solve complex mysteries.
I want to leave you with this final medical pearl from our source material. Treat the patient, not the image. A brain lesion is not always a brain tumor. It's such a powerful reminder that in medicine, and honestly in any complex problem-solving scenario, the most obvious answer is sometimes just a disguise. We have to look past the surface image to uncover the truth underneath. So what assumptions are you anchoring to in your own life that might be leading you down the wrong path? Think about that for a second. Thanks for joining me on this explainer, and keep asking the right questions.